G'day, I'm Ted Jedinak, podiatrist and international educator of health practitioners in manual therapies, helping you get better results clinically and commercially. I'm really excited about this opportunity I have for you today because you are going to get some key content that'll help you in your clinics immediately. I saw some posts on Facebook this week about the biomechanics summer school that was held in Manchester in the UK, and it just made me stop and go, what? I need to find out more about that. So I contacted my friend and colleague Simon Bartold, who happened to be one of the presenters at the summer school, to ask him to share the learnings and to answer my questions, and I'm really grateful to have him on the other end of the line. So thank you, Simon, for taking my call.
Thanks, Ted. It's a great pleasure to be here. Welcome from a beautiful sunny day in Annecy in France.
Nice. Sounds gorgeous. Now, before we get stuck into this call, let me introduce Simon to you. Now, he probably doesn't really need any introduction, but if you don't know who Simon is, what cave have you been living in? Look, I did ask Simon to send me a brief summary of his CV for this interview, and somewhat facetiously asked him just to limit it to 21 major accomplishments, given his extensive experience. And well, bugger me if he didn't send me a list of 22. So let me cherry pick the key points for you. Now, you may not know the incredible similarities that Simon and I share. We actually trained together in our undergraduate podiatry course. Now, Simon was dux of the course and I wasn't. Simon has studied and written and lectured extensively in sports medicine topics, and I haven't. He has received awards for his contributions to biomechanics by the American Podiatric Medical Association. Simon's also been a consultant podiatrist to the British Cricket Academy, the Indian cricket team, Australian Sports Institute. He's been deputy director of the podiatry services at Olympic Games, of which he's attended 4 times, and I haven't, and university appointments, blah, blah, blah. But his tome, The Foot and Leg in Sport, is certainly a must-have. Simon's currently based in France as manager of global footwear specialist programs, so yes, he does know a thing or two. The term overachiever comes to mind, but anyway, it's been said that the level of mental acuity can be reflected in men by their receding hairline, and well, let's just say I still have a full head of hair. So anyway, thank you, Simon, for being willing to share your expertise with the FMT tribe. It's much appreciated. Okay, so this interview is to glean the top lessons that were offered at the Biomechanics Summer School. Now, the first topic that grabbed me was accompanied by a photo of a number of the participants. Now, all wearing this t-shirt claiming the death of overpronation. Simon, what's going on? Have I had it wrong for the last 30 years? Are you telling me that overpronation doesn't exist?
Well, there's a couple of points you brought up there, Ted. First of all, receding hairlines, I think, are probably caused by a very high concentration of testosterone in the system. It's got nothing to do with so there you go. So lots of the good stuff floating around. And actually, the t-shirts we were wearing didn't say the death of overpronation, and it said,
"Oh no,
I love overpronation."
Yes, no, but
and it said that specific.
No, hang on a second. Yeah,
to stir up our mate Ian Griffiths, who was lecturing on the topic, and he was proposing that we should bury overpronation.
That's right.
It's a pretty interesting topic.
Sorry, no, I'm going to cut in. I'm going to cut in here because he was the photograph you also had was a rest in peace, a cemetery headstone with the death of overpronation. So I apologise for getting that wrong.
No, that's okay. And yeah, look, it's a very interesting and very important point, and Ian's a very interesting young fellow, very dynamic young podiatrist from the UK, and basically the point he was making is that we should really stop talking about overpronation, which of course is based on Root, Weed and Orion's theories from 1973.
Yep.
And his premise was we should stop talking about it because nobody actually knows what it is. And if I can expand on that a bit, it's a very interesting point, because if I were to say to you, Ted, well, can you describe what overpronation is? I bet you can't, and I bet nobody who's listening to this podcast can either, because there is no definition of what it is. And we are working on a theory that's now well over 40 years old, that is based on an assumption for criteria of normalcy. Now, if we have a think about that in relation to human variability, it's a bit of a nonsense, really, because there's no such thing as a normal human, which I'm sure you'd identify with, Ted.
Sure. Ooh, low blow.
So,
He's come out with
many
a
different
forearm
levels.
jab. Okay.
So we can't actually get to the starting line. We can't get to the starting line of saying, well, this amount of pronation is abnormal, or that amount of pronation is abnormal, or supination for that matter, because we simply don't have terms of reference. We don't have any sort of definition to say, well, this is actually normal.
Oh,
I
well,
could show
hang on a sec. Let me just jump in here. If we have a joint and whoever, one individual person, and we've got their subtalar joint, and as we know, pronation is a motion that happens in all three planes. When that specific joint gets to its end range position and is subjected to forces that push it into those physiological limits, is that not excessive pronation or maximum pronation, or could that not be called, or is that what we're inaccurately or incorrectly calling overpronation?
I think the point of the discussion, we'll maybe revisit that. We'll revisit what you've just said in a moment. But I think the point of the discussion here is that there's a whole industry that's been built around a concept that you can somehow identify a person as being abnormally pronated.
Okay.
And the issue here is that nobody can actually define those terms. So if we've got, say, an athletic footwear company that's using the wet footprint test on the bathroom floor to say, yes, you're either high arched, normally arched, or low arched, and therefore you must be a supinator, a neutral foot type, or an overpronator, is complete and utter nonsense. I mean, it doesn't relate to the real person at all. And then to assume that you could somehow prescribe a shoe that was a motion control shoe for an overpronator, or a neutral shoe for a neutral foot, all the research tells us that, again, that simply can't, that doesn't match. There is no correlation there at all. And then we could get into the thorny topic of orthotic therapy and say, okay, well, I'm measuring you in relaxed calcaneal stance, and you've got 5 degrees of calcaneal eversion in relaxed calcaneal stance, even though we know if we had 10 people measure it, it would probably be different for those 10 different people.
Yep.
And I'm therefore going to put you into an orthotic to stop you from overpronating. How do we know that person is not functioning perfectly normally and perfectly adequately at a position of 5 degrees eversion? And the answer is we don't.
Okay, yes.
So we have to have a complete rethink on how we approach this. Now, that's not to say, I'm not suggesting that there aren't some people who may be in a movement pattern or a range of a joint that is pathological and likely to create injury. That certainly is completely likely and feasible. But the point is, we need to stop using terms that imply that we somehow understand, based on a static examination,
Yes.
which I'm not keen on, as you know,
Yep.
that somehow imply that we know where to draw the line in the sand, because we don't.
Okay, so from a practical clinical perspective, if we just put aside the static examination of a patient or a case, put that to one side, what do you recommend, or how would clinicians go about doing a dynamic examination?
Okay, so that's a really good question, because as podiatrists and probably also quite a few physios have been brought up, they've been weaned on the concept of root theory.
Yeah.
Now, I want to make it quite clear that I think that Root, Weed and O'Ryan made a tremendous contribution to our body of knowledge over many, many years, but what people tend to forget is that it's called root theory, and the important word is theory. It was only ever a theory, and somehow, somewhere, it became cast in stone as a fact, and it just isn't a fact. And the second problem I have with it is that it's an off-weight bearing form of assessment in terms of looking at the joint ranges of motion, and it doesn't describe the quality of motion at all. And then it's a weight-bearing examination to try to establish neutral calcaneal stance, which is fraught with error and fraught with intra and inter-tester unreliability.
Yes.
And so really we have some real issues with this. You don't. The third point I'd like to make is that you don't, especially in sport, you don't get injured standing still in the anatomical position. There's no sport that allows you to do that. Okay.
Oh, now you've got my
So,
mind thinking. There's got to be.
yeah, well, I mean, I'm thinking of creating that sport, but I'm not sure it'd have too many takers. But so you get injured when you move, and the key thing about dynamic assessment is that you're trying to understand the movement pattern that might have created the injury in a dynamic sense, and so you're trying to understand that, and you're trying to replicate it when you examine the patient.
Yeah.
So the first thing I say to people is, look, rather than putting people on the couch after you've taken your incredibly detailed history. I think you should actually not be putting them on the couch, and I think you should actually be putting them through a series of dynamic tests. Things like just looking at very simple tests like squatting, single leg squat, drop jumps, lunge testing, all these sorts of things that give you a functional dynamic assessment of that athlete that you can actually measure.
Yes.
For most of them, you can actually look at that. So you've got a proper reference point of where the deficit lies. Yeah, so a really simple example of a dynamic test is the lunge test, and this is straightforward. So you just measure out 10 centimetres from a support wall. If you can't get your knee to the wall, like your knee literally touching the wall from 10 centimetres back, well, then we know both functionally and dynamically you've got a limitation in your ankle joint range of motion.
Yes.
That's one of the single most important biomechanical problems. I mean, that has a huge knock-on effect all the way up the kinetic chain.
Yes.
It's very easy to quantify. It's dead simple to do. And we should be doing that as a part of our assessment protocol for every single person we see coming through through the clinic with some sort of musculoskeletal injury.
What impact does the dynamic examination have versus the static examination?
Yeah, well, again, it's a really good question. I mean, I think that what we're looking for a lot of the times in dynamic assessment is what you're particularly interested in. So we're looking for limitations of normal range of motion that allow you to function within our normal envelope is what I'm particularly interested in.
Yep.
So if you've got a limitation of ankle joint dorsiflexion, well, clearly you're not going to fix that with an orthotic device. You need to look at how you can improve that.
Yes.
So you'd look at trying to change the range of motion through the ankle, either with mobilisation or Mulligan technique, or or aggressive stretching, all of which are quite effective.
Yes.
But we have the discussion about orthoses because it's quite important, because obviously what we know about orthotic devices is an overwhelming mountain of evidence saying they do work, an overwhelming concept that we're still not really quite sure how they work, but we've got some clues. But I think that the whole concept of people who are really thinking about this and who are successful with orthotic therapy, they're taking a completely different approach to this, Ted.
Okay.
And they're not really using the standard routine approach where, you might have a 4-degree inverted device on a balanced cast, blah, blah, blah.
Yes.
Because, often people are just trotting out the same prescription for the same patient, and there's tremendous variability in terms of foot morphology, biomechanics, weight, gender, genetics, blah, 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 blah.
Yes.
So what we're talking about now is something called a tissue stress model. And a tissue stress model is, again, there's no hard evidence behind it, but it fits what we do clinically far better than any other model that I'm familiar with. And basically what we're doing here is we're using a model that specifically identifies the anatomical structures that are the problem. So the patient comes in and says, "Hey doc, I've got whatever, heel pain, shin pain." So we go about our examination. We find the anatomical structure. We say, okay, we think it's your tibia, and we're thinking maybe it's a tibial stress fracture. Who knows? And then from there, we're going to try to figure out the structural and or functional variables that could be the source of the pathological force on the structure. Okay. So we're not immediately saying, oh, let's have a look at whether you're pronated or not. And yes, I can see you're pronated, and therefore that is the problem. We're actually trying to get an idea about all of the forces that might be loading that structure.
Yes.
So if we take tibial stress fracture, it's quite a good example. So what we know about tibial stress fractures is that they occur secondary to a bending moment. In other words, if you imagine when you heel, we'll assume for the sake of this argument that we're dealing with a heel striker. When your heel strikes the ground, you've got two ways that the bone is loaded. you get ground reaction force and you get muscle force. Okay.
Yep.
So the ground reaction force will bend the bone in one direction, and it normally bends it so that it bends concave posteriorly. So you can imagine that if you've got you get a little flexible stick and you push it against the ground, it's going to bow backwards.
Yes.
So that's the ground reaction force action. Because human engineering is so fantastic, we've got a counterbalancing force, and that's the muscle action. So the muscle action of particularly triceps surae, it bends the bone in the other direction. So it bends the bone forward. So we've got this yin and yang occurring. And you can then imagine that we've got a problem where we get an imbalance between that yin and yang. So if we get an increased posterior bending moment, because we've got either weak calf muscles or we've got small calf muscles, then you're going to increase the bending moment of the tibia, and you're going to, it might fail. And typically stress fractures occur in the posterior medial aspect of the tibia. So they typically occur under tension. Alrighty, so that's a bit of an in-depth description, but what we're dealing with here is we're trying to understand the stress on the tissue.
Yes.
Is it from muscle? Is it from bone? If it's from muscle, well, then we need to think about how we might change that. And so it's not so much about saying we need to correct this by X degrees or Y degrees. It's about how can we use an orthotic to change the position of the foot to create a moment in a direction that's going to influence the issue that's caused the injury. So you design the orthosis and the treatment plan, and this is very important because it's not just an orthosis.
Yes.
You design the orthosis and the treatment plan, which is you design this in a manner that's going to most effectively reduce the pathological force on that injured structure. And more importantly, you're going to try to optimize your gait function in a way that's not going to create other pathology or symptoms. So that's the essence of tissue stress theory.
Yes.
And it makes much more sense than just saying, right, you've got plantar heel pain, you're pronated, whack you into a 4-degree inverted device and we'll see how you go. Pat them on the hip, pat them on the bum and send them on their way.
Yes.
It's taking a much more logical approach to try to understand exactly what caused the problem rather than just say it's got to be the foot.
Great. Okay, that's an excellent summary there. All right. We are going to launch now into the second topic of the biomechanics summer school, and that was the great debate: foot mobilization versus orthotic therapy. So my first question here is, how could there be a great debate on this subject without me? Who was on the panel that could represent the foot mobilisation corner? Answer that question for me.
Well, in fact, you were mentioned quite a lot in the great debate. Your name came up. It was normally either preceded or followed by a swear word.
Yes. Why doesn't that surprise me?
Your name certainly did come up from time to time, and it's a very good question because you should have been there.
Yeah.
But it's interesting. I'll just give you an idea I'll give you a thumbnail of what this was about. So the panel was Ian Griffiths, who's a young dynamic pod from the UK.
Yep.
It was another fellow called Ian Horsley, who's a PhD physiotherapist. It was me, so the black sheep. It was Kevin Kirby, who's a very, very well-known and respected American podiatrist.
Yep.
And it was Chris Nestor, who's a incredibly well-respected research podiatrist. And when this question was posed, this was the great debate. We basically all looked at each other and said, well, this is going to be the shortest debate ever because there is nothing to debate here. You can't possibly separate these two topics. Basically, it's patient specific. Some patients are going to get much more benefit from manipulation. Some patients are going to get much more benefit from orthotic therapy. But if you're really smart, you might use both and get an even better result. And that's pretty much the way the discussion went.
Were there 3 top points made in this great TED list, or was that the one point, or is it just that summary that you came up with? Is that it?
No, I think that's much more the way it was. I think that everybody agreed that when you try to compartmentalize treatment programs for the incredibly varied human organism, then you're setting yourself up for failure.
Yeah.
Because you're not thinking outside the square, and you're not actually taking a far more global approach to patient care. So I think everybody agreed with that. And you know, understanding that you had people on that panel who have never been exposed to manipulation or mobilisation, you know, Kevin Kirby probably being one who really is very entrenched in orthotic therapy, but he certainly was quite vocal in saying there is no right or wrong way to treat a patient. It's very much specific to that individual on a needs basis. And it's a bit like the whole minimalist argument, you know.
Yes.
Of course, it's brought us a lot of interesting points and it's added a lot of value to the discussion. But anybody who says you should only be running in a minimalist shoe or should only be running barefoot is just as dopey as anybody who's saying you should only be running in a motion control shoe. You know, because it just doesn't make any sense. We're really not in a brave new world here now. You know, I think we're making progress, and I think evidence base is a good foundation for every profession. But anybody who doesn't actually embrace the concept, I think, of clinical results. I mean, I would like to think that I'm fairly evidence-based, but I'm also quite happy to think outside the square and understand that there's a whole lot of stuff we don't know yet. And we do have some therapies that we don't understand very well at all that do get good clinical results. And I can give you an example here of my own experiment of one where I had raging plantar fasciitis, which every clinician should be forced to experience. And I did everything a good podiatrist would do. You know, I taped it. I used ice bottles. I stretched. I did everything. I drank a lot of whiskey, and that didn't help it. And the only thing that helped it was when my friend and colleague Brenton Bowen actually released a trigger point in my lateral gastrocnemius, and it got better in one treatment. Okay, so that's the experiment of one. But since then, I've become interested in this, and I've looked at the research that's out there, and there's actually quite a bit of evidence for trigger point therapy for plantar heel pain.
Geez. Look, you should have come to me straight away.
As I've become older, I've become more skeptical and less skeptical. So I try to take notice of people who appear to be getting good clinical results reliably, and just try to research that a bit better.
Yep.
So I think we got off topic there a bit, but it is interesting that, you know, you can become very bound up and forget that there is a bit of art to the science of medicine.
Yes, no, I think there certainly is. Look, I've just got to pull you back on the plantar fasciitis because I went to an excellent lecture and presentation in Townsville last year, and the presenter was giving very clear evidence that it's actually a misunderstanding. The plantar fascia itself is not, plantar fasciitis is not an inflammatory condition of the plantar fascia. Now, who was the guy that was talking about that? Bartold, I think his name was. So, yes. So what are you talking about? You couldn't have had plantar fasciitis in the first place.
I said plantar heel pain, I'm sure.
Yeah.
But, yeah, well, I mean, I think the whole thing is that plantar fasciitis is actually, it's actually a diagnosis, and it is inflammatory. But what we think now is that most people who present with plantar heel pain don't have plantar fasciitis.
Oh, nice save.
That's the key point.
Yes, good distinction. All right. Now, look, I see time is galloping ahead. Let me just summarise the key takeaway points that I've gotten from this discussion. The first one about the definition of hyperpronation and the fact that because we don't have a standard of normalcy for human bodies, and as far as subtalar and mid-tarsal joint hyperpronation or pronation goes, or for any, I should correct that, say we don't have a normalcy for human bodies with what a normal range of pronation is, therefore we can't use the term hyperpronation or overpronation. Second point was, I'd love your perspective on the marketing of the athletic shoe producing companies. And I think if I've written down here, utter nonsense. The research doesn't support what's being promoted. No surprise there. The third key point here, the tissue stress model. This is definitely something that I think as health practitioners dealing with musculoskeletal conditions, we need to pay very close attention to this because there's, as you described, it is helping explain what we're seeing in a clinical perspective from a treatment and results-based element. Nice work. I do want to, of course, make sure that everyone listening can take away one practical action that they can apply in their clinics immediately. And if I was going to pick one, it would be make sure you are absolutely all over the lunge test. So if you're not sure about how that actually happens, I'm sure there's going to be, I'll throw up a link on YouTube. It's very clear, very simple, but the impact that reduced ankle dorsiflexion has on not only locally at the foot and ankle level, but the whole kinetic chain is a fascinating impact on the human body. Don't ignore it at your peril, I guess, is the key thing. Simon, I want to say thank you very much for your attention. Were you going to throw in with one more comment there, or were you going to let me wrap this up?
No, I was just, as you were saying that one key point, and I was just thinking in my own mind, and my take-home message would be definitely dynamic function is what you need to be looking at. So just think about how they got injured, why they got injured, and then try to understand the mechanism for that. And you're delving into it immediately a lot deeper, and you're much more likely to get a good result if you take that approach.
Nice, sage advice there. If you want to keep up with the latest developments and critically reviewed research on the foot and leg in sporting matters, then go to bartoldbiomechanics.com and join up. Do I get a spotter's fee for that plug? No, you don't have to answer that. It's okay.
No, nicely said, though.
Oh, good. Okay, so thanks everyone for listening to this podcast. Until next time, serve with spirit, consult with care, and keep helping the health of humanity today.